So I'd like to now introduce Professor David Reutens. Professor Reutens is the director of the Center for Advanced Imaging, with prior positions as the Professor of Neuroscience at Monash University and Director of Neurology at Southern Health. Professor Reutens is a clinical neurologist specializing in epilepsy and is a senior staff specialist at the Royal Brisbane and Women's Hospital. His current research is based around epilepsy with a focus on epileptogenesis and anti-epileptogenic therapies, which has yielded new treatments targets related to inflammatory mechanisms. This research may be used to help predict the likely course of developing epilepsy and thereby contribute to the development of diagnostic and disease-modifying strategies. So I'll pass you all on to David Reutens.
Can I just check that I'm sharing my slides? The topic of the power of imaging in advancing health and medical science, which is rather challenging to do in 20 minutes. And I was also asked to talk about how I became a clinician-scientist and to provide some insights into the skills necessary to succeed and how my clinical work impacts on my research and vice versa. As Isaac said, I'm a neurologist specializing in the treatment of epilepsy, and I'm also director of the Center for Advanced Imaging at UQ. So I studied medicine at UWA, and I remember deciding that I wanted to be a neurologist when I diagnosed a lateral medullary stroke in third year. And it sort of felt like being Sherlock Holmes, being able to deduce the location of a tiny stroke by matching clinical signs with the anatomy of tracts in the brainstem. Although, ironically, imaging has made this skill largely redundant in most situations. But once I set on the path of becoming a neurologist, I was fortunate in having many good mentors and models. And I guess there's something for students. Really, mentors and models are very important in your future career. I began neurology training at Royal Perth when Mercy Sadker was head of department, and she was Australia's first female neurologist, meticulous clinically and a tireless advocate for her patients. I decided to subspecialize in epileptology because at the time, and this was before there were any acute treatments for stroke or treatments for MS, at the time epilepsy was one of the few areas in neurology where you could actually cure patients. And I was an epilepsy fellow at the Austin Hospital in Melbourne, where I worked with Peter Bladen, who was a visionary who established the first comprehensive epilepsy programs and stroke centres in Australia. Sam Berkovic, a giant in the genetics of epilepsy, and who'd also done pioneering work in imaging, was my supervisor. But at that time, my research interests were largely in ways of measuring cortical excitability in patients with generalized epilepsy using magnetic stimulation. I then spent a year at Queen Square, which is the main neurology hospital in Britain. And there were sort of many famous neurologists per square metre, but the one who stands out in my memory was David Marsden, whose work was in movement disorders. And I got to see firsthand his method of careful patient observation and then of formulating hypotheses that were based on thoughtful synthesis of these observations. I was then a NHMRC travelling fellow at the Montreal Neurological Institute, where Wilder Penfield had pioneered epilepsy surgery, and he'd become famous for mapping brain function by electrically stimulating the cortex in awake patients. Penfield designed the MNI with tight integration of clinical care and research in mind, to the extent that the clinical floors alternated with research labs. And in keeping with his philosophy, in the foyer, he put the statue of nature unveiling herself to science. At MNI, I worked with Fred Anderman, another very astute observer of clinical phenomena, and who was also keen to incorporate new imaging technologies into epilepsy surgery workup. And because I wanted to study physiology and microanatomy in the living human brain, I learned skills to do so with Alan Evans, who was then developing many of the tools that we use for computational anatomy and brain mapping. And I also worked with Albert Gedde, who was using PET tracer kinetic modeling to study brain energy metabolism. I mean, there are other skills that you need to be a successful clinician scientist. I learned how to lead as the director of neurology at Southern Health, which is now Monash Health, which is the largest healthcare network in Victoria. And there I had important experiences like leading process improvement and culture change, introducing new clinical practices such as stroke thrombolysis, and also an important skill of learning how to manage a team of people. And Pam has sort of mentioned the skills of diplomacy, which you need in that sort of job. In 2008, I was recruited to UQ to establish a new imaging research centre, and had the chance to learn a whole new set of skills involved in funding and organising large projects. So in 2010, Julia Gillard announced funding from the Education Investment Fund to build and equip CAI, which now houses about $60 million worth of advanced imaging equipment for preclinical and human imaging across the range, from ultra-high field MRI to molecular imaging to radiochemistry and cyclotron facilities. I mean, the other thing to note is that researchers are really professional beggars. So as the saying goes, no money, no science. And over the years, I've had plenty of practice in writing grants that have funded my research continuously since returning to Australia. And currently one of the bigger grants is an ARC-funded, Australian Research Council-funded training centre for innovation in biomedical imaging technology, which trains industry-ready PhDs in collaboration with several industry partners in the areas of smart imaging probes and smart scanning techniques. In 2008, I also started as a staff specialist in neurology at Royal Brisbane. And after several years of lobbying, in 2015, we were able to get funding to establish a statewide comprehensive epilepsy surgery program. And that included funding for a 3-bed epilepsy monitoring unit and funding to grow a multidisciplinary team of epileptologists, neurosurgeons, nurses, neuropsychologists, neuropsychiatrists, and neurophysiologists. And also to start an epilepsy fellowship program to train the next generation of epilepsy specialists. So let's segue into how my clinical work impacts on my research and vice versa. Translational research is like a fountain. We have a large group of patients with epilepsy who require clinical and diagnostic services. And clinical observations on these patients and observations of the processes and economics of care delivery influence research on how we use our imaging tools. And they also motivate preclinical and technology development research, which is then trialed and translated into clinical application. So how does this work for me? My patients have recurrent epileptic seizures that are caused by the abnormal firing of nerve cells in the brain. Now, epilepsy impacts all facets of the patient's life, with a global burden equivalent to lung cancer in men and breast cancer in women. And in fact, the burden of disease and the healthcare costs and the risk of injury and death are greatest in the third of patients who have uncontrolled seizures despite the optimal use of medications. And in a subset of these, the subset with seizures that begin in one spot or a focus in the brain, there's a potential to be cured by epilepsy surgery. And many studies have now shown the benefits of surgery. Patients become seizure-free, mortality is reduced, cognition, quality of life, psychiatric comorbidities improve, and healthcare costs are reduced. Although surprisingly, there's still evidence of under or delayed referral of patients with intractable epilepsy for surgery. So imaging has had a large impact on how we work up patients for surgery. During pre-surgical investigation, there are really only two main questions. The first is, where is the epileptogenic focus, and can it be cut out, resected safely? So we're dependent on the concordance of multiple lines of investigation. And there's a saying in pre-surgical workup that the workup's complete when the ducts line up. When I began training, the mainstay of investigation was really only just EEG, either from the scalp or from electrodes implanted in the brain. So what we do was that the patient was admitted to the epilepsy monitoring unit, medications were reduced so that the patient started to have seizures, and then the video and EEG correlates of the seizures were recorded. Imaging modalities at that time weren't generally that useful. And to assess potential deficit, often we needed to do direct cortical stimulation, where after the skull is opened, the general anesthetic is turned off and the patient's allowed to wake up, and then the surgeon stimulates the cortex electrically while the patient, for example, performs a language task or reports on sensory symptoms. We also used the WADA test, where the anesthetic agent amobarbital was injected into the carotid artery to anesthetize one hemisphere so that we could lateralize language or memory functions. So over time, imaging has become a major part of pre-surgical workup, with intraictal MRI and PET scans, ictal SPECT scans, and functional MRI, giving us greater confidence because there are more ducts to line up, and also reducing the need for invasive tests like implantation of electrodes. So this is a CT scan of a 43-year-old patient with temporal lobe seizures that persisted despite 4 anti-seizure medications. To illustrate the burden of epilepsy, during her seizures, she actually used to become asystolic, and so she needed a pacemaker inserted. And then she developed a paraplegia from a spinal cord infarct. And I wondered at this time whether she might have had a fibrocartilaginous embolus related to a seizure, but this is very hard to prove. Anyway, the CT looks pretty unremarkable, but the MRI shows a bleb here, which looks like what we call an encephalocele. So when we looked at that area on fluorodeoxyglucose PET, we found hypometabolism, so reduced metabolism here compared to the other side, which is a pattern that we commonly see in epileptogenic tissue. So the encephalocele was resected in January, and the patient's been seizure-free since. In patients with temporal lobe epilepsy due to mesial temporal sclerosis, and this is just the histology of that pathology, and people with HS are the largest group of patients who come to surgery, and the imaging has largely removed the need to insert electrodes in the temporal lobe to record seizures, because we can actually see the atrophy and signal change, and we can see the reduced hypometabolism on PET. Imaging also helps us to rule out surgery early. For example, in this patient with seizures due to a double cortex malformation, here you can see the second band of cortical tissue due to disrupted neuronal migration during development caused by a mutation in the double cortin gene. So in this case, we were able to go down the path of neuromodulation early rather than thinking about resection, and the patient had a vagal nerve stimulator implanted. Increasingly, however, we're trying to find more and more subtle changes, such as localized areas of blurring in the grey-white matter boundary and small areas of PET hypometabolism, such as in this patient who was having frontal lobe seizures 3 or 4 times a night. This appearance is very suggestive of focal cortical dysplasia. And some of my research is in trying to identify how these small changes in microarchitecture can be detected accurately with imaging and detected automatically. Because we know that the different microstructural features such as myelin content or iron content and the density of cell bodies and fibers influences signal in different MRI sequences. So one of my postdocs, Shahzad Moinian, is looking at how we can use just one MRI acquisition based on a technique called magnetic resonance fingerprinting to pick up these signal changes. And we're exploiting the residual signal after we've accounted for the effects of the main MR relaxation constants. And then we apply machine learning and map the features to the cortical surface. And so as proof of principle, we've been looking at how well this works and just parcellating normal cortex into microarchitecturally distinct Brodmann areas. And it performs quite well in separating out cortical regions such as the motor and premotor cortex or different parts of Broca's area. Now, in some patients, to localize the epileptic focus, we inject a blood flow tracer labeled with radioactive technetium as soon as we can after seizure onset when the patients are in for video EEG monitoring. So we know that blood flow increases in regions that are firing off abnormally, and these show up as a hotspot on ictal SPECT scans. But to be sure that the hyperperfusion is real, we need to compare the ictal SPECT with a SPECT scan performed when the patient's been seizure-free for 48 hours. And so we subtract the interictal from the ictal scan to reveal the true area of hyperfusion. But then the need for an interictal SPECT leads to delays in diagnosis, and it also leads to further radiation exposure for the patient. So one of my PhD students is in FAHMS is using artificial intelligence deep learning methods based on convolutional neural networks with multiple hidden layers to estimate the interictal SPECT image. So she's trained a generative adversarial network using previously acquired images from our monitoring patients to synthesize the interictal SPECT from interictal MRI and interictal PET scans. And we're now validating this against the real interictal SPECT and the real subtraction results. So hopefully we can do away with a second interictal SPECT scan and get to the diagnosis quicker. We also use functional MRI to localize key functions such as language, motor function that might be threatened by surgery. Surgery encroaches on the eloquent cortex. So this is a patient who has an epileptic focus close to the area of a previous resection of a brain tumor. And the question was whether resecting additional tissue anterior to the previous resection margin where the seizures are coming from would threaten language. And you can see with functional MRI that there's activation in that area during the performance of a sentence completion task. So fMRI is a well-established method for mapping signal changes that reflect the hemodynamic changes and the changes in blood oxygenation that are coupled with neuronal activation. And conventionally, we use a task-based paradigm where the patient performs a cognitive task in a fixed time sequence. But unfortunately, epilepsy patients with attentional and other cognitive problems often find it difficult to complete the tasks, and we end up with an indeterminate result. And the experience itself can be quite unpleasant. Typically, we use a battery of tasks. So for example, in language, we might tap into the different aspects of language, including generative and receptive language. And this makes the scanning sessions long. To overcome these drawbacks, a patient of mine, Elaine Kwan, a PhD student of mine, is working on machine learning methods to extract the same information using a naturalistic movie watching stimulus. So looking into the crystal ball, what are the trends in biomedical imaging? One of them is the development of targeted imaging and therapeutic probes, particularly for cancer. And at CAI, we've been funded to establish a new national facility for the development of targeted radiometals, especially alpha particle emitting radioisotopes for the treatment of cancer. Another push is to increase cost effectiveness and patient comfort by shortening imaging times with the assistance of artificial intelligence. And a PhD student of mine, Hamid Muradi, is working on the use of AI to shorten PET acquisition times. while also obtaining additional physiological information from the time course of tracer uptake. In future, I think we're going to see increasing datification of images and less reliance on qualitative interpretation. And in addition to the example of estimating specific PET kinetic parameters, we're also using mathematical models to quantitate tissue microstructures in MRI-based methods. AI is going to have an increasing role in multiple aspects of imaging, including image reconstruction. And here's an example of what PhD student Rajat Vashistar has been able to achieve with AI-based PET reconstruction to counteract some of the artifacts and to increase robustness against noise. Because if we can increase noise robustness, we can reduce the amount of tracer that's injected and reduce the radiation dose to the patient. Another big problem is that MR scanners are limited in their availability. So patients in developing countries have limited or no access at all to MRI. And in developed countries such as Australia, waiting times are still long. People in remote and regional areas have to travel to larger centres because the current scanners require special sighting to deal with their weight, with the magnetic field. They're costly to buy and to run, and they require cryogens like liquid helium. They also need highly trained operators. So a low-cost cryogen-free portable MRI scanner would get around some of these problems, and this is a system that we're prototyping based on some of our patents using dynamic permanent magnet Holbach arrays. So I also get to do things which are literally out of left field, although I guess food security and climate change do impact health. So this year we're setting up an agricultural imaging facility to allow researchers to use MRI to image growing plants. And that's for work to develop crop strains for better root carbon capture, increased drought and heat tolerance and so forth. We're also using this for imaging native species, and this is a species, the brain of a species of lizard. So I'll end here. I hope this has given you some idea of my trajectory as a clinician scientist. Thank you very much.
That was fascinating, and I feel like people would agree that you're still acting the part of Sherlock Holmes, just with finer tools at your disposal now with these imaging techniques which have been developed. I do have a question here. When using imaging techniques, particularly related to like glucose uptake and metabolism in the brain, to identify focal areas of seizure, do you think there's a potential translational aspect to the use of and the improvement of these technologies? And the example used here was such as in Alzheimer's disease, where I understand there's a downregulation of GLUT1, GLUT3 transporters in areas where there's high tau burden as a way of...
I mean, there's been quite a bit of work looking at FDG PET in dementia, as well as, you know, the work using tracers which specifically target tau and amyloid. But there's certainly been a lot of work on that aspect of things. And one of the things that we're just commissioning now in CAI is a hyperpolarizer, which allows us to increase the MR signal from C13 labeled metabolites. And one of the very first projects will be one looking at C13 pyruvate in mouse models of Alzheimer's disease.
That sounds fascinating. And you mentioned just at the end there that there's projects looking at improving carbon capture is that in crops or in general species of plants? Could you talk a bit more about that?
And, you know, historically, plants have been bred to have as little carbon in their roots and as little carbon in their leaves as possible, so that all the mass and energy is pumped into the product, the fruits or whatever. But there's increasing interest in actually increasing the root biomass in crops. because that actually then serves as a capacitor for carbon, and it decays slowly over time, but it gives you another buffer for atmospheric carbon dioxide.
That's fascinating. I just love those translational aspects which are highlighted by this sort of research as well.